Good morning. Hi, everyone. My name is Stephanie Suarez Gonzalez. I am the Clinic Partnership Manager for MAVEN Project. Thank you all for joining us today and our friends at Lynn Community Health Center for hosting today's session, Adolescents with Bleeding Disorders, Who, What, and How to Treat with Dr. Joanna Davis. Dr. Davis started the Pediatric Hemophilia Treatment Center at the University of Miami in 1987 and has remained the medical director since that time. The program expanded from 6 patients to now a lifespan center with a focus on education and outreach to both the medical and lay communities. Dr. Davis has developed several lectures highlighting the basics of coagulation, challenges faced by women affected by a bleeding disorder, current approaches to the management of the hemophilias, von Willebrand disease, and rare bleeding disorders. And with that, I will pass it over to Dr. Davis.
All right. Thank you. And thanks for getting up early and having probably your second cup of coffee. As Stephanie said, I have a particular interest in women with bleeding disorders. And over the years that I was involved with the HTC, the Hemophilia Treatment Center, we evolved into having a girls' clinic. Increasingly over the last easily 10 to 15 years, the recognition that women have bleeding disorders has become a forefront for those of us who are taking care of patients with coagulation challenges. And as primary care physicians who are taking care of teenagers, I am sure that you have your share of girls with heavy periods, iron deficiency, anemia, and to a certain extent, there seems to be a little bit of a waffling. What do we do? Who do we order labs on? And with our girls' clinic, referred to as the Cycle Clinic, we partner with an adolescent GYN. So I give a shout out to Dr. Sims for her expertise in helping to frame how we now are managing these girls who are referred to us. So that being said, my disclosures, I serve as a medical board advisor and a speaker for Sanofi Genzyme, and I am on the board of advisors for Genentech as well. Okay. So what are the learning objectives? To identify when to evaluate patients with heavy menstrual bleeding for an underlying bleeding disorder, to recognize von Willebrand disease using clinical assessment measures and laboratory testing according to evidence-based practices, to develop therapeutic approaches for adolescents with bleeding disorders and the implications for clinical practice, and to explain how adolescent medicine physicians can support a young woman with a bleeding disorder when hemophilia treatment centers, also called HTCs, or pediatric hematologists are not readily available. At the end of this talk, I would like to think that everybody would be able to recognize abnormal heavy menstrual bleeding beyond the usual, yeah, my periods are terrible, and yeah, I bleed a lot. Able to capture important elements of the menstrual history, identify historical clues suggesting a patient may have a bleeding disorder, know how to ask strategic family history details, order appropriate lab tests, and initiate therapy for iron deficiency anemia, as well as the first steps for trying to stop the heavy bleeding. So we're going to do this case with a case presentation. So this is Molly and her mortifying menses. So a 14-year-old presents as an urgent visit to the clinic referred by her pediatrician. She had been sent home from school, having flooded her clothes during her period. Turns out that this is happening every month for the last year. Her mother, her sisters, and her aunts all report heavy periods. So you as the clinician, you go, I know that this kid probably has a bleeding disorder, but she's 14. Why is there such a delay? Just as a vocabulary update, we no longer, at least those of us in the bleeding disorders community, we don't call it menorrhagia anymore. It's called heavy menstrual bleeding, or HMB. So if you see that terminology either through the presentation or in your day-to-day dealings, that's what it means. It used to be menorrhagia. So reality check, women do have bleeding disorders. There are at least 1 million women and girls in the United States with a bleeding disorder, but only about 20,000 know about it. Other than pregnancy, the most common reasons that women seek medical attention are heavy menstrual bleeding, HMB, or iron deficiency anemia, IDA. We love our initials. What's fascinating, and this was a real aha moment, at least in my trajectory, to find out that 20 to 30% of women with heavy menstrual bleeding will turn out to have an undiagnosed bleeding disorder. And 15 to 25% of women with iron deficiency anemia may also have an undiagnosed bleeding disorder. I mean, that's huge. So what are the bleeding disorders common in women? Well, the most common disorder worldwide is von Willebrand disease, and we'll talk about that a little bit more in a bit. But carrier status for hemophilia A or B is the second most common bleeding disorder found in women. Women who carry the gene for hemophilia A or B, and remember, these are X-linked disorders. So women who carry the gene may be asymptomatic, normal factor levels, no unusual bleeding, or they may have low factor levels and actually have bleeding symptoms and will be classified by hematology as having mild hemophilia. And we'll talk more about that in a bit. Other factor deficiencies, which we do see not uncommonly in our girls' clinic, although they are not common in the general world, are factor 7 deficiency, factor 11 deficiency, which is particularly common in Eastern European Jewish extraction. And by the way, it only takes one Polish great-great-grandma for that gene to be floating around and has come to rest in your patient. So part of the history is, I always ask, where's the family from? Please don't say Florida. Please don't say the United States. Go back a few generations. And I have identified girls with factor 11 deficiency who are not Jewish in their day-to-day life, but there was a grandma or a great-grandma from Eastern Europe. There are other rare factor deficiencies, factor 13, factor 5. There are defects in the fibrinolytic pathway. We form a clot with the procoagulants or the clot-forming elements, and instantly the clot is starting to be attacked. And that is the fibrinolytic, or as I say to patients, the clot busting system. And these two exist in balance, which is what keeps us on a fairly even keel. But you can have defects in the proteins involved in the clot busting pathway as well. And you can certainly have platelet problems, either a deficiency of platelets or they don't work right. And the two most common ones are Bernard-Soulier syndrome, which is a defect in the adhesion of platelets to the breach in the endothelial layer, or Glanzmann's thrombocythemia, which is a problem for aggregation of platelets or platelets clumping up on top of each other to form a platelet plug. That being said, one slide only for a basic science review. This, by the way, is kind of like what a clot would look like under an electron microscope. So you have your blood vessel and it's leaking. If it's leaking, there's a tear in the endothelial layer. The blood is coming out. So what happens? In a nutshell, you have several things that happen all at once. Primary hemostasis occurs when the blood vessel tries to squeeze itself shut and the platelets are activated and move to the area of the broken endothelial layer. They move with the assistance of von Willebrand's factor, von Willebrand protein, and they glom on down to the basement membrane to cover it over. That's primary hemostasis. However, this platelet clot which forms is very delicate and very lacy. There are gaps between the platelets as they've sort of stuck and spread out and heaped on top of each other. So if nothing happens, those holes are weak points and the clot's going to fall apart. So within an hour or so of it forming, bleeding will either restart if it's stopped, or it's going to increase in intensity. Secondary hemostasis, or the fluid phase of hemostasis, is also known as the clotting cascade. The regular, orderly, predictable activation pathway of the clotting factors, and there's a whole bunch of them, which are dissolved in the liquid portion of the blood, doing nothing until they're needed, and then one is activated, the first turns on the second, the third, the fourth. So you have this waterfall effect. and you have the formation of a biological glue or cement, which is called fibrin. The fibrin fills in the gaps between these platelets. I tell families platelets are like Velcro. And the fibrin fills in the gaps between the Velcro platelets and makes the clot tight. Now, I explained the clotting cascade to families like the guy who sets up the dominoes. You're in Massachusetts, so you have attics and you have basements too. In Florida, we don't have basements. Who sets it up in the attic, knocks one over, and they all fall down. And everybody has seen it. Everybody has tried it. I mean, everybody knows this, even the little kids. So I asked them to imagine this line of dominoes. Each domino is a clotting protein, a clotting factor. And I say, okay, I've knocked the first one over, and now I'm going to pull out one. What's going to happen? And even the little kids get it. It stops. Exactly right. You're not going to knock over that last domino. You're not going to make fibrin. So if you have a clotting factor deficiency, you basically have interrupted this domino pathway. We measure the integrity of the clotting cascade with the ProTime and with the PTT. Those two tests measure the amount of time looking at two different arms of this clotting cascade that it takes for blood to form a clot in a test tube. And it's measured in seconds. So if you get a prolonged PT, 9 to 14 seconds, depending on lab, reagent, you get a PT of like 20 seconds. And a normal PTT, you're really looking for factor 7 deficiency. It's the only factor in the PT pathway that you're worried about. If you get a PTT of 40 seconds, 50 seconds, and that's normally up to about 34 seconds, but your PT is normal, then you're looking at a defect in the intrinsic pathway, or factors 12, 11, 9, 8. Okay. So again, million women in the United States with a bleeding disorder, maybe 25,000 know about it. Why? What's the reason for the delay? And there's a great article, and you'll get the slides, called Sexism in the Management of Bleeding Disorders. There's a lack of knowledge among healthcare providers, certainly among families, that women have bleeding disorders. The focus has, for generations, been on men in hemophilia, particularly when starting in the late 70s, early 80s with the HIV epidemic. Until recently, there have been fewer resources for women and girls. There is a lack of awareness that women who are carriers for hemophilia A or B can bleed. And this is due to the lion hypothesis, which some of you may remember from medical school. Okay. Women have two X chromosomes. That's redundant. We don't need to be functioning with both up and running. During embryogenesis in a female, one X chromosome in every cell is turned off at random. So depending on the proportion of X chromosomes that are carrying the hemophilia gene, depending on if most of those are turned off at random, that woman will not have any bleeding manifestations and will have normal factor levels. She's still carrying the gene. The same woman, same genotype, now imagine that the majority of her normal X chromosomes are shut off. This is a woman who's going to be functioning with lower factor 8 or 9 levels, bleeding manifestations, and indeed, depending on how much factor 8 or 9 activity she has, can be classified as a mild hemophiliac. So the new term, again, vocabulary update for lionization, is skewed X inactivation. Now, again, if you look at a strict genetic diagnosis of a carrier state, it is someone who has a gene for a disorder but does not manifest the signs or symptoms of that disease. And we had a lot of trouble with insurance companies with that definition, because women were either called asymptomatic or silent carriers, they weren't bleeding, or symptomatic carriers. But because of the use of the word carriers, a lot of the insurance companies 10, 15, 20 years ago would not cover their health care for any unusual bleeding. So there evolved a way of trying to to objectively present the fact that these women actually are having bleeding manifestations while you're waiting for the factor levels to come back. BATs are bleeding assessment tools. You can pull off 1 million of them from the internet. And basically, it's an organized set of questions. It's a screening tool going through different types of bleeding manifestations, nosebleeds, gum bleeding, bruising, periods, postpartum hemorrhage, but broken down depending on the BAT that you use in terms of how many questions are being asked, and they're scored. The more symptoms you have, the higher your BAT score. So you can see in this side, that a bleeding assessment tool for women who do not have a coagulation disorder has a BAT of about 1. And as long as you've got a BAT of 1 or 2, depending on the score, maybe 3, you're considered to not really be significantly evidencing a possible bleeding disorder. But look at hemophilia A carriers. You got a BAT around 5 and probably more, okay? But again, there's a discrepancy. Women who are carrying the gene will have more bleeding symptoms. Now, PBAC is another graphic representation of excessive bleeding. This is specifically for menstrual bleeding, and there'll be a picture of it later on. But again, the higher your PBAC score, the more likely you are to have a bleeding disorder. And if you've got a PBAC of like over 150, 200, it's almost diagnostic of a bleeding disorder. It's not going to tell you which one, but you need more workup. Did you know that the first case in the literature of a woman with hemophilia who was diagnosed in middle age, at age 10, she bled significantly with a tooth extraction, and she had multiple hemorrhagic episodes, including heavy menstrual bleeding. And that was the first case in the literature that was presented, but there was no further mention in the literature of a female carrier until 25 years later. In 1925, Erik von Willebrand identified a family in the Åland Islands off Finland with a different disorder, which was ultimately labeled von Willebrand disease. On the average, there is a delay of 16 years between the onset of symptoms in a female and the diagnosis of a bleeding disorder. For males with hemophilia, usually severes or moderates, we'll talk about that in a minute, most of these are identified and diagnosed within the first year of life, looking at a delay of 16 years. Now, we did a study down at UM a couple of years ago, retrospective study, looking at 100 adolescents identified or admitted with heavy menstrual bleeding or iron deficiency anemia between 2015 and 2021. So of those 100, almost half were diagnosed with an underlying bleeding disorder. And even in a place where you've got an HTC, where you've got people who are kind of on top of this, the average time to diagnosis from menarche was 4.5 years. Could have been a lot longer if these were girls who had nosebleeds or easy bruising. And this was published in the American Journal of Pediatric and Adolescent Gynecology. This just shows you the graphic for Dr. von Willebrand. It was a farming community. One of her brothers bled to death when he got his arm caught in a thresher and he just bled out. 4 of her siblings died before the age of 4 due to uncontrollable bleeding, and she ultimately bled to death during her 4th menstrual period. So von Willebrand's disease is the most common inherited bleeding disorder in the universe. It occurs in 1 to 3% of the population worldwide, but bleeding symptoms are usually disregarded. To a certain extent, there's like, oh, it's nuisance bleeding. I've heard that term, nosebleeds or easy bruising or gum bleeding. Males and females are equally affected. This is an equal opportunity disorder. Doesn't matter where country you come from, what your religious beliefs are, what your gender is, what your pronouns are, doesn't matter. 1 to 3% of the world. But women are disproportionately burdened because of reproductive bleeding, childbirth, and menses. There are 3 subtypes, and most patients have mild disease type 1. So type 1 is a quantitative disorder. People make a less than normal amount of a functional protein. It accounts for about 3/4 of cases identified, and the symptoms are usually mild: bruising, heavy periods, gingival bleeding when you brush your teeth, nose bleeding. These are the common ones. And think about your own practice. When do you start to get concerned about bruising and nosebleeds and gingival bleeding? Type 3 is the severe form. It's rare, 1 in a million. Unlike the others, it's autosomal recessive. Type 1 is dominant. There is a complete deficiency of von Willebrand protein. Now, what's fascinating is that von Willebrand factor or von Willebrand antigen is a huge protein. It's huge. It has binding sites for the endothelial layer for collagen, right? So that's what it does in primary hemostasis. It sucks itself down onto the breach in the endothelium. It has binding sites for platelets. It attracts the platelets to come and start to heap up and form that primary platelet plug. But it also has binding sites for clotting factor 8, which is the clotting protein which is deficient in hemophilia A. Clotting factor 8 is tiny. If left to its own devices, it would be almost instantly cleared out of the circulation, and we would all have severe hemophilia A. But because of the attachment to the large von Willebrand protein, the half-life of our factor 8 is extended 5-fold, and we go on about our business, right? In people who do not make any von Willebrand protein, there's no factor 8 either, because there's nothing for it to bind to. So the type 3s actually have symptoms like hemophilia, including joint and muscle bleeds. It's often mistaken for hemophilia. You may hear the terms, oh, it's a female with hemophilia. Well, now you know that, yeah, women can have hemophilia, but a lot of the times it was referring to patients who had von Willebrand's disease, severe, or the subtype of von Willebrand's disease that doesn't bind well to factor 8, which brings us to the type 2s. That's everything in between. About 15 to 20% of cases. Unlike the types 1 and 3, which are quantitative, this is qualitative. There's something wrong. The protein's built wrong. It either doesn't stick well to collagen, it doesn't stick well to platelets, it doesn't stick well to factor 8. And there is a specific test which needs to be done to identify the subtype of von Willebrand's, which has implications for management. And that's the multimer, the building block of the von Willebrand protein. So let's go back to talking about hemophilia. What is it? It's an X-linked recessive disorder, which if you have hemophilia A or classical hemophilia, that's factor 8 deficiency. The incidence or the prevalence is pretty constant over decades. 1 in every 5 to 10,000 live male births will be affected by hemophilia A. Factor 9 deficiency is also hemophilia B, or Christmas disease, affects every 1 in 25 to 30,000 live male births. They're very similar, but we have learned that factor 9 deficiency is a little bit different because of the way factor 9 navigates through the extravascular space and through the bloodstream. We grade the hemophilias on the amount of that clotting factor, which can be measured in a blood test. The severes are the ones who have basically no detectable factor 8 or factor 9. Usually reported as less than 1%. Some labs may say less than 2%. Bottom line, these are the people who are at risk for life or limb-threatening bleeding with little or no trauma. These are the people who are usually identified in the newborn period because of unusual bruising, bleeding, cephalohematomas, bruising when they come out, prolonged bleeding from venipunctures, or even worse, arterial punctures. Moderates 1 to 5%. Interestingly, you don't need the mystical, magical 50 to 150% normal factor levels of any of them to have a fairly reasonable, albeit sedentary existence. Yes, with trauma, yes, with surgery, moderates are going to have unusual bleeding. But in and of themselves, maybe they'll bruise, They're not going to be allowed to play certain sports. For women who do have this level, they will have heavy periods. And the milds, now it's 5 to 40%, because 40 to 50% has now been reclassified as near normal. Don't ask me why. But anyway, these are people we may never see unless they come to a surgical situation. Somebody gets a PT-PTT as part of pre-op screening, and lo and behold, the PTT is prolonged. There's a 30% spontaneous mutation rate for the hemophilias and for von Willebrand's disease, meaning no matter how hard you look, you're not going to find it in a family member. But the traditional pattern of inheritance is from a father who has hemophilia. Remember, men are challenged. They only have one X chromosome. So whatever their X chromosome says in terms of production of factor 8 or factor 9, it's going to be expressed. So you have dad with hemophilia and mom who has no hemophilia gene. All of his daughters will inherit his hemophilia gene. He only has one X to give. All of his daughters will be what we call obligate carriers, regardless of whether they have symptoms or they're mild hemophiliacs or they're totally fine. None of his sons will have hemophilia. You can have a woman who is a genetic carrier for hemophilia, and she may not even know it. Okay. And she has a child with a man who doesn't have hemophilia. Well, every male that she conceives has a 50-50 chance of getting her hemophilia gene. So any male that she has a 50-50 chance of being a hemophiliac. Remember, the men only have one X. Any daughter she conceives has a 50-50 chance of inheriting the hemophilia gene, and therefore has a 50-50 chance of being a carrier. Again, symptomatic or not symptomatic, depends. So let's go back to our case. Mortified Molly turns out to be very shy and doesn't like talking about her periods. She hates having her blood drawn and is terrified of her needles. What do we ask, and what labs do we really need? The American College of Obstetrics and Gynecology came out with this in 2015. They really haven't updated it too much. I love it. It's called Using the Menstrual Cycle as a Vital Sign. So in general, normal menstrual cycles, menarche average is 12.43 years. The mean cycle interval is 32.2 days in the first gynecologic year. The interval is typically 21 to 45 days. So the 28-day cycle, if somebody comes to you and says, my periods are lasting 35 days, that doesn't necessarily mean that there's anything wrong. Flow length is 7 days or less, and 3 to 6 pads or tampons per day is the usual. Now, when do you suspect a bleeding disorder? Remember, we're talking now, this is what's going to build into that PBAC. Bleeding for longer than 7 days, flooding or gushing blood that limits daily activities, social activities, school, exercise, routinely passing clots that are at least the size of a quarter, not once in a while, but every period. Changing a tampon and or pad every hour or less on the heaviest day and the product is saturated. Caveat, always ask them what is the absorbency of the product that they're using. Because if a girl is just using mini pads because she doesn't like the feeling of a bulky pad between her legs, that's a lot different if you're changing a mini pad every hour and it's soaked versus I'm using double overnight pads during the day and it's saturated in an hour and a half. So always ask, what are they using? Now, for a regular period, there should be less than 35 milligrams of iron loss per period, which means that the cycle itself should be less than 80 mils per cycle. And actually, back in the day, people would collect pads and tampons and wring them out and weigh them and figure out how much blood was being lost. We don't have to do that today. The thing which is an important take-home lesson, I think, for all of us is, according to the International OBGYN Society, or FIGO, if a girl says her periods are too heavy, start with that. It's too heavy, and then keep on going. Maybe there's not a bleeding disorder. Maybe it really isn't. Maybe she's using mini pads, whatever. But we all need to obviously take our patients' complaints or questions seriously. So other clues, any anemia symptoms or a history of anemia, treatment for iron deficiency in the past, a history of nosebleeds, gum bleeding, easy bruising, family history of bleeding symptoms, and bleeding disorders, especially heavy menses or postpartum hemorrhage in female relatives, nosebleeds in male relatives. It's really not enough to say anyone in the family have heavy periods, okay? I like to ask if there have been any females on either side of the family, because remember, male, it can come through the dad's side, von Willebrand's or hemophilia, who either received or were recommended transfusion, endometrial ablation, hysterectomy as management for heavy periods or postpartum hemorrhage. Other important GYN history for the person in front of you, any previous use of oral contraceptives, sexually active. Does she have significant dysmenorrhea? Because endometriosis can cause prolonged, painful, irregular periods without being associated with a bleeding disorder, although girls with von Willebrand's may be more likely to have endometriosis. And just part of your past medical history, is there a history of migraines with aura, DVT, PE in the family, because that may preclude the use of estrogens, history liver, kidney, gallbladder disease, use of seizure medication. And we always do the psychosocial head interview to assess for major stressors triggering bleeding. And heads, as you can see from the footnote, home, education, employment, eating, activities, drugs, sexuality, suicidal ideations, safety. This is recognized as triggers for heavy periods. And sometimes this girl's periods can just be completely out of whack because she's stressed about 12 AP classes and her boyfriend just broke up with her and her parents are getting a divorce. I mean, we've just seen this so many times. So what do you order? A pregnancy test. Molly may be shy, but still waters run deep. Always CBC diff for tick and platelet count. You want to make sure that you're not missing a thrombocytopenia, an aplastic anemia, obviously a blood leukemia type of a picture. Always the reticulocyte count, because it gives you a measure as to whether or not the marrow is responding to the low hemoglobin. Blood type and cross-match if the hemoglobin is under 7 or if she's symptomatic. Iron profile, PT-PTT. In general, grab a von Willebrand disease panel, and which includes the von Willebrand factor activity, antigen, the ristocetin cofactor, which is a measure of the interactivity with platelets. Always factor 8, because remember, factor 8 lives with the von Willebrand protein, and this may give you a tip-off that maybe you're dealing with more of a carrier situation, and those von Willebrand multimers. Because type 2s can have all normal numbers all across the board, but it's the multimers which are going to tell you that there's a problem. In general, we will repeat the von Willebrand workup at least one more time, if not 2. We want to get away from a stress situation. In all of us, factor 8 and von Willebrand protein are stored in the cells that line the blood vessel. Part of the fight or flight response is under the influence of the adrenaline rush, is to dump it out into the circulation for it to get to work. Makes sense, right? Well, you don't have to be being chased by a lion to have a fight or flight response. I've had girls who are so nervous walking into clinic and seeing that it's an oncology clinic and they know they have cancer and they know that they're dying, that they just spontaneously release their factor 8 von Willebrand. I have girls who are so needle phobic that as soon as they hear that they're going to have a blood test, they start hyperventilating and they will shed it as well. Certainly the little kids, as soon as they hear about a blood test, they're running around the clinic screaming their heads off, and that's another adrenaline rush. But recent infection, ongoing viral infection, hyperthyroidism, birth control pills, high estrogen states, all of these will raise your von Willebrand factor 8 profile so that you will need to repeat this. If her periods are irregular, get a TSH. If parents are consanguineous, it's usually a nice icebreaker. So are you and her dad, first cousins? There's a higher incidence of factor VII deficiency in consanguineous populations. And if the family history is suggestive of Eastern European descent, get a factor 11 as well. If obese or with hirsutism and irregular cycles, check A1C, testosterone, DHEA sulfate, prolactin level, but we're talking PCOS now, which is a whole other lecture, not in my wheelhouse. And obviously, if sexually active, a urine GC and chlamydia. Do you need an ultrasound? You can. It's done externally. You're looking for something like a bicornuate uterus. Fibroids are rare in teens, but can occur. You're looking for the thickness of the endometrium as well. If you can identify it, if this is a non-virginal girl, you can certainly do an intravaginal ultrasound. You may identify a malignancy. However, try to manage the bleeding, because what you're going to see is not going to change what you need to do if she's actively bleeding right now. And in most situations, there's no need for an internal exam. And this is coming from my GYN. So what about her sister? Sister's 11 years old, admitted to the hospital with a hemoglobin of 5.4, had been seen at her pediatrician with a complaint of heavy menses and was found to have severe anemia on a HemoQ. In the hospital, her PTT was 34 seconds, which was only slightly prolonged, and bleeding disorder studies are pending. What would you do? Now, again, remembering that fight or flight response, the PTT may be normalized or shortened because of this release reaction. So an APTT of 34, it's only 1 second off, so it's okay. No, it may not be okay. It may just be falsely normalized due to the situation. And you're going to get this slide. Please don't ask me to do it. But this is a screenshot of the management plan that we have at This is in our ER, this is in our adolescent clinics, this is in our girls' cycle clinic, and it just really goes through step by step. And I know that you're going to get the slides. I think that this is of tremendous use for practitioners who are seeing these girls. Now, what about treating the anemia? What if it's severe? So consider hospitalizing the patient if her hemoglobin is 7 or less, or she's orthostatic or tachycardic, or she's actively bleeding heavily. You want to stabilize her like everybody else, crystalloid, order lab evaluation for bleeding disorders. If you can get it done before starting any kind of hormone therapy, again, remembering that estrogens will raise the levels of von Willebrand panel, then do it. Stopping the bleeding. This is what our GYN uses. Use oral contraceptive taper, starting QID for 48 hours, decreasing to TID, or use IV Premarin, 25 milligrams IV Q6 until bleeding stops, and then switching to an oral contraceptive every 8 hours. Use a monophasic with at least 30 micrograms of ethinyl estradiol, and preferably levonorgestrel or norgestrel. The estrogen is the most important part. Start every 6 hours, taper to every 8 hours when the bleeding stops, and then there's going to be an interim visit to figure out which way to go. And always remember to provide antiemetics when you're using this much estrogen. You can also use continuous oral medroxyprogesterone if you have someone that really can't take estrogens. We rely a lot on agestin or norethindrone. This is not the mini pill progesterone. This is not birth control. And we start the girls 10 milligrams twice daily. When the period stops, we cut them down to once a day and then 5 milligrams a day, which they just stay on. And it usually just suppresses their periods and everybody is really happy. If possible, avoid Depo-Provera, because if you're dealing with somebody who has an underlying bleeding disorder, you could cause a deep muscle bleed with the IM injection until you've identified what the problem is. Now, remember I spoke about the clot busting system. So here's another tool in the toolbox. If we want to stop the bleeding, either we replace a factor which is missing, right? Or we try to keep the clots hanging around a little bit longer. So once a clot is formed, plasminogen is absorbed onto the lysine residues of the fibrin mesh. And under the action of TPA and urokinase, it is converted to plasmin, and plasmin lyses the fibrin mesh and lyses fibrinogen and dissolves the clot. That's the mechanism of how we break up a clot. Antifibrinolytics block the conversion of plasminogen to plasmin, extending the life of the fibrin mesh, extending the life of the clot, and controlling the bleeding longer. The one which is labeled for use in vaginal bleeding is tranexamic acid, or TXA, brand name Lystida. And it is safe to use even with combined oral contraceptives. It's not going to make somebody hyperclot. And it's also safe to use if you have a kid who has heterozygous for factor V Leiden or prothrombin gene. This is safe to use. The prescription is 2 pills 3 times a day for the first 5 days of a menstrual period. And it works across the spectrum for heavy menstrual bleeding, regardless of cause. Don't forget iron. Consider IV iron if the girl is in the hospital, because teens can really struggle with oral iron. Either it makes them feel sick or they forget to take it. Be sure to send them home on ferrous gluconate, ideally 325 BID, that's 65 milligrams of elemental iron in each tablet. Take it with food or vitamin C, and be upfront about the side effects. They may need a stool softener, they may need to switch formulations, but don't forget the iron. Transfuse only for severe symptoms, not a hemoglobin, because these are healthy patients. Limit transfusions in adolescent girls to avoid antibody production and future isoimmunization with hemolytic disease of the fetus during a future pregnancy. Give 1 unit and check the hemoglobin. Do not automatically give 2 units. And in general, healthy adolescent girls can tolerate hemoglobins of 5 to 6 and recover well, as long as the bleeding has stopped and iron therapy is initiated. So Molly is found to have mildly low von Willebrand. What would you do? Our GYN and in general, the feeling is that the Mirena IUD or levonorgestrel IUD is the way to go. Okay, you can put it into virginal girls. They're tiny. Our GYN does it all the time. A lot of parental pushback about that, though, depending culturally. They don't want their girls to not be virgins because they have an IUD. But this is the best way to go. And then these are some others. This is coming from ACOG and the American Academy of Pediatrics. Concern about infection risk. The risk of PID is at insertion 0 to 2% risk. If there's no infection, 0 to 5% if infection is present, but document chlamydia and gonorrhea status prior to insertion. Treat infections if present. This has been shown to be much more effective in terms of reducing menstrual blood loss than either antifibrinolytic agents alone, the tranexamic acid, or contraceptives, and prostaglandin synthetase inhibitors. Follow up the testing, send these girls to hematology. We want to ideally get them in as estrogen-free a situation as possible. Sometimes it's not if they're like on continuous pill without the placebo week, but if they're on a pill which is cycling, we try to bring them in on the day that they're due to start the regular pill, the last day of the placebo. And hemophilia treatment centers have expanded. We're not just taking care of boys and men with hemophilia anymore. There's a real role for the HTCs in women with bleeding disorders. We educate, we support women's programs, we provide prenatal care, pregnancy and delivery plans, we co-manage heavy menstrual bleeding, coordinate surgery. This gives you an idea of everything which is involved. And this is a critical tool. There are other options for resources for women. One of them is the National Bleeding Disorders Foundation, formerly National Hemophilia Foundation. The other is the Foundation for Women and Girls with Bleeding Disorders. You can look them up. They have all sorts of resources. Another is for rare bleeding disorders, ladybugs, and there are specifics for each disease state. If you go to www.cdc.gov, you can find a hemophilia treatment center near you, although given today's climate, I'm not sure where things are going with that, but at least the resources are there for now, and contact phone numbers for providers who can help you. So I'm going to stop. I think I'm on time, and I'm happy to entertain questions. For me, this has just been, in terms of managing girls with bleeding disorders, it's really been life-changing. I remember my first patient with von Willebrand's disease. She was 14. Didn't know she had, nobody knew anything. It's just that she kept bleeding through all of her clothes all the time. She was always anemic. And I'm in Florida. These girls can run around all year long in bathing suits, white shorts, short skirts, and she couldn't because she was bleeding so much. And we were able to diagnose her, get her on appropriate intervention, and it literally changed her life. And that to me was a real aha moment. So I will stop talking and open it up for questions.
Thank you, Dr. Davis. So as we mentioned earlier, feel free to use the Q&A option to submit any questions you might have. And while we're waiting for questions, I'm going to just drop a few reminders into the chat. Give me 1 second. So again, reminder for those that joined us a little bit later, a reminder about the CME survey. The CME survey will appear in a tab when you close out of this webinar. We really do appreciate you taking a few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best sessions for you. We do share the feedback anonymously with the speakers, and they greatly appreciate your thoughts. And with that, I think we have our first question. Give me 1 moment. No, just somebody saying thank you so much. Superb lecture. They learned a lot. I'm going to drop this in the chat for everyone. Any questions from anyone? I think it's, oh, there's one question. There we go. Okay, so one question for you, Dr. Davis. Any specific population seeing von Willebrand disease?
No, there really isn't. It's across the board. You just need to have it in the back of your head. There are others, for example, like I said, factor 11 deficiency, if you can identify Eastern European extraction. Here in Florida, we have a very localized enclave of Guatemalan Indians in Palm Beach County, and they tend to intermarry. And the incidence of factor 7 is very high in that population. So again, it's kind of knowing what's around there. But in general, you can screen anybody for von Willebrand's disease.
Great question. And I'm dropping another reminder in the chat. We do offer mentoring here at MAVEN Project. So that is something that is available to all of our clinic partners as well. All right. I'll give it another minute just in case there are anyone type is there, and just in case anybody is typing. Sorry, I obviously haven't had enough coffee myself this morning. But outside of that, we do appreciate everybody joining this morning. As always, Dr. Davis, your lecture was amazing, and I learned a lot, so thank you so much. But outside of that, if there are no other questions, I will give everybody back the rest of their morning. And thank you again to our partners at Lynn Community Health Center for hosting today's session.
Have good days, everybody.
We could actually, sorry, there was one question. There we go. Okay. So there was somebody still typing. A woman in her early 39-ish with Crohn's and episodic leg bilateral bruising, not anemic, normal CBC and coagulation levels. What lab should they check?
Well, Crohn's is a whole different ballgame. And I think you can certainly start with a von Willebrand screening. I've identified patients with von Willebrand's disease in their 20s. And I think that you also may want to consider getting platelet studies. I don't know what medication this woman is on. I don't know the extent of her autoimmunity, but platelet aggregation studies are looking specifically at the patient's platelets. It's not just the number, it's how well they work. And taking them in the lab and exposing the platelets to different chemicals and literally getting a tracing for how fast it forms a clot and everything else. Medications can affect platelet function without affecting platelet number. And always you screen for von Willebrand's, but it would probably, in a woman like this, make sense to look and make sure her platelets are working right. It may involve some change in the medications which she is being prescribed. The other thing I would double check, although they shouldn't be using NSAIDs, make sure that this is not somebody who is using Motrin or Advil or something like that, because those medications in general will interfere with platelet function in anybody. And the labs that do platelet function tests can separate out a drug effect from one of the inherited tendencies.
Awesome. Well, all right, so it looks like there aren't any other questions. Thank you again, Dr. Davis. Actually, wait. Oh, yes, she said thank you.
Okay.
All right, so thank you again, Dr. Davis and Lynn Community Health Center for hosting today's session. Again, your CME survey will pop up. And if there's any questions, please don't hesitate to reach out. Thank you, everyone.
Bye.
Bye.